Welcome to UMCC Medical Consultant Connectors, where your health matters to us. Kindly like, subscribe, and share for more. Pelvic fractures and hip dislocations are severe orthopedic emergencies, usually from high-energy trauma like car crashes or major falls. The pelvis protects vital organs. Breaks can cause massive bleeding and instability. Hip dislocations, often with pelvic fractures, require significant force. These injuries demand immediate action from the medical team. Prioritize the primary survey: airway, breathing, circulation, disability, exposure, addressing life threats first. Apply a pelvic binder early to stabilize the pelvis. These injuries often indicate multiple traumas. Manage the critically injured patient with urgency. Swift, coordinated care can be life-saving. About 90% of hip dislocations are posterior, often from a dashboard injury in a car crash. The classic sign: the leg is flexed, adducted, internally rotated, and appears shortened. This should immediately suggest a posterior dislocation. Anterior dislocations are less common, usually from forced abduction and external rotation. Think of a fall with the leg forced outward. Here, the leg is abducted, externally rotated, and may appear lengthened. Sometimes the femoral head is palpable in the groin. Limb position is the key clinical clue. Fadir, flexion, adduction, internal rotation for posterior. Abduction and external rotation for anterior. Quick visual assessment guides diagnosis and anticipates nerve or vessel injury. Posterior dislocations risk sciatic nerve injury. Anterior can threaten femoral nerve or vessels. This distinction is crucial for choosing the right reduction technique. Using the wrong maneuver can worsen the injury. Accurate diagnosis based on limb position is the first step to safe, effective treatment. Hip dislocation reduction is an orthopedic emergency. Time is critical. Recognize, differentiate, and act fast. Major pelvic fractures present with severe pain, inability to move or bear weight, visible bruising or swelling in the pelvic region. Pelvic instability or leg length discrepancy may signal a serious fracture, but examine gently. Provocative maneuvers can worsen bleeding. Hip dislocations cause intense pain, and a fixed, abnormal limb position, shortened and internally rotated for posterior, abducted and externally rotated for anterior. Always perform a thorough neurovascular exam, checking sensation, motor function, and pulses, especially for sciatic nerve injury. Initial imaging starts with an AP pelvis X-ray as part of trauma protocols. This quickly identifies major disruptions. If a fracture is seen, apply a pelvic binder immediately. Additional X-ray views help clarify the injury, but CT scan is the gold standard for full assessment. CT provides detailed 3D images to reveal hidden fractures or joint involvement. For hip dislocations, a post-reduction CT is essential to confirm proper alignment and rule out trapped bone fragments. Early, accurate imaging guides all further management. Rapid diagnosis is key to preventing complications. Every step from exam to imaging must be systematic and thorough. This approach saves lives and limbs. Immediate management of unstable pelvic fractures focuses on hemorrhage control. Apply a pelvic binder at the greater trochanters right away. If bleeding persists, escalate to angiographic embolization or surgical pelvic packing. Stabilizing circulation always comes first. Once stable, definitive fracture treatment depends on stability. Stable patterns may be managed non-operatively, but unstable fractures usually need surgical fixation. The goal is to restore anatomy and allow early mobilization. Hip dislocations are true emergencies. Reduce within 6 hours to prevent avascular necrosis. Closed reduction under sedation is standard, using gentle, specific maneuvers. After reduction, reassess hip stability and get a post-reduction CT to check for fragments or associated fractures. If the hip is stable and uninjured, manage with protected weight bearing. If unstable or with major fractures, proceed to open reduction and internal fixation. Timely, coordinated care is essential for the best outcomes. Every decision should be guided by injury pattern and patient stability. Early intervention saves function and lives. Severe pelvic fractures can cause life-threatening bleeding, organ injury, and long-term pain or disability. Chronic issues include malunion, nerve damage, and difficulty walking. Hip dislocations risk avascular necrosis. Even with prompt reduction, up to 20% may develop this complication. Post-traumatic arthritis and sciatic nerve injury are also concerns. Prevention starts with aggressive resuscitation, early stabilization, and timely surgery for pelvic fractures. Early mobilization reduces risks of blood clots and pneumonia. For hip dislocations, urgent reduction is critical. Every minute counts to preserve blood supply. Streamlined protocols from ER to OR are vital. Best practice is a systematic, multidisciplinary approach. Stabilize first, image thoroughly, and plan definitive care. Always confirm reduction with CT and check for associated injuries. Attention to detail at every step minimizes long-term disability. Our goal is not just survival, but restoring function and quality of life. Excellence in trauma care makes all the difference. UMCC, your ultimate medical consultant connectors.